Okay, good afternoon. My name is Dr. Alabi. I'm a consultant gynecologist and I currently work in South Shore Women's and Children Hospital, Lagos, Nigeria. I'll be presenting a review of our management of ectopic pregnancy in South Shore between February 2012 and May 2021. This project was done by myself and my colleague, Dr. Damilola Oduyebo. Greetings from Lagos. This is some part of Lagos at night. Lagos is known for its nightlife. So if you're in Lagos at any time, let us know and we can hang out. The bill is on you though. Okay, so our outline is introduction, aim, method, result, discussion, recommendation, and conclusion. I declare no conflict of interest. And basically, this is what we're talking about really. So these four pictures illustrate ectopic. The first one is somebody that had a hemoperitoneum. I mean, interestingly, she's an IVF pregnant woman who has 3 embryos transferred. One of them implanted in the left fallopian tube and the 2 other implanted in the uterus. So she was still, she's a heterotropic pregnancy. The one below it is a lady who had IUI and got pregnant, and it's a tubal ectopic, and that's after treatment. And that is the skin of the same lady after we've done the surgery, illustrating basically what minimal access surgery is. This is a video of the same patient. I'm not sure it will show. Let me see. Okay, it's not showing. So let's quickly, and that's after we remove the tube. So incidence of ectopic in Nigeria is about 1.5 to 2.7 per 100 deliveries. This is from study by a lot of people in Nigeria, but the one I'm quoting here is Sotubo Amakinde, and there are several others, but the range falls within that range. The commonest presentation is abdominal pain, and ectopic is currently responsible for about 8.5% of maternal deaths in Lagos, Nigeria, and has a case fatality of 3.7%. As you know, it's very notoriously bad to get data in Nigeria, so I'm sure it's probably more than that, but a lot of people don't report to hospitals. The risk factors are pelvic inflammatory disease, pelvic infection, pelvic surgeries, previous pelvic surgery, postpartum and post-abortal sepsis. The peculiarity of Nigeria is that we don't have early pregnancy assessment unit like other countries where things are picked up a lot earlier and allow treatment even before a rupture and stuff like that. We also don't have easy access to quantitative beta ECG, and even when it's available, we don't get the result on time. Patient present late to the hospital. So our aim is to review the diagnosis and management of ectopic in our hospital, look at the diagnostic tool we use, look at the treatment option for managing the patient and any complication that could have arose from the treatment. We use as standard the RCOG and the NICE guideline for ectopic pregnancy. And our review is a retrospective audit. Questionnaires were designed and used for data collection. The study population was gotten from theater register and the pharmacy records. Results were analyzed by using SPSS version 27. Right, most of the patients were either self-referral or referral from facilities, especially the IVF centers around us. And some of the patients are our own patients as well that are receiving antenatal check in our hospital. The commonest presentation is about 68.2%, and is abdominal pain. The mean gestational age for our patients is 7 weeks. And the further gestation we had was 12 weeks pregnant lady. Adnexal mass with empty uterus is the commonest scan finding. For the commonest scan finding. Number of women treated for ectopic in our facility within this period is 23 women, and the number of deliveries were 246 deliveries, giving us a prevalence of 9.2 per 100 live births at South Shore. Most of the pregnant women in our hospital deliver abroad, so that's probably, if they are delivered in Nigeria, I'm sure that our prevalence will be a lot more lesser. The mean age of our patient is 30.9. Other studies have 30 as well, and this study, a particular study from Abuja, is about 26 years, 26.7 years. Now, almost 60% of our patients are nulliparous, and half of the group have fertility issue before they're ectopic. From the patients, 22 patients had surgery, and 19 had salpingectomy, and 3 had salpingotomy. The 21 had successful surgery by laparoscopy, while one of them was converted to open surgery for technical reason. I remember that patient vividly. She was operated on whilst we were on AGIS conference in Port Harcourt in 2019. And they had technical issues, so they had to do it the safest way, which they converted it to open. One patient had a successful treatment with methotrexate, and I remember her clearly. She has actually had, I think she's had 2 children after that, both of them born in South Shore. One of the laparoscopy that had methotrexate in another facility was referred when her abdominal pain was getting worse and her beta ICG was increasing, so we proceeded to a laparoscopy. 78% of our patients had beta ICG done before surgery, and 17.4% had none done, showing that they probably had evidence of ectopic on scan, showing that either they have a gestational sac with fetal pole with FH, or they have significant fluid in their abdominal cavity with, they have blood in the abdominal cavity with beta ICG. And 4.3 were not documented. Out of the people that had the surgery, 10 were ruptured, 10 were unruptured, slowly leaking, some of them, and 3 were not documented. Most studies in Nigeria shows a very high percentage of ruptured ectopic, about 83.1%. The status of the contralateral tube. In our patients, 17 patients had a normal contralateral fallopian tube, 3 had unhealthy, 1 was absent, and 2 they were not documented. One patient who has salpingotomy had repeated beta ICG afterwards. One who had methotrexate had few beta ICG and none in the rest, 21 patients. The average blood loss in our patient is 246 mils. We had a 1,500 mils, but this was, this is the blood we met in the abdominal cavity. So I think sometimes with ectopic it's very difficult. When you do the surgery itself is almost bloodless, but the amount of blood that you see there is probably what you call the estimated blood loss. There was a couple of studies that we looked at, Bangladesh, China, they seems to have, this is the average blood loss they are quoting. In our study, the average day patient stay in hospital is 2 days, ranging from 1 to 4. I think one of the issues with discharging patients here is that sometimes you worry about them coming back to hospital and the traffic and everything. So sometimes you want them to stay for at least 48 hours, unlike most developed countries that people can go home within 24 hours. There was not a lot of complication. 19 had no issues. 1 had surgical site infection. Another one had severe pain. And there were evidence of oliguria, which were corrected with intravenous fluid. So in our conclusion, I will conclude that laparoscopic surgery is the mainstay of ectopic treatment in South Shore. We hope to re-audit in about 2 years, including their pregnancy outcome post-surgery. We want to emphasize methotrexate as a suitable option, but we are aware that a lot of our patients or patients referred from fertility center are trying to conceive and are reluctant to use methotrexate as they want to try to conceive immediately after their surgery. Our recommendations are that a lot of ectopics can be treated with methotrexate or laparoscopy. If we do not catch them early, and that negates methotrexate, I think laparoscopy should be a suitable alternative. Because of the lesser risk of addition formation equating to lesser subfertility related problem, lesser pain, pelvic pain, units in Nigeria should be encouraged to start programs where specialists can be trained with skill to perform laparoscopic surgery for ectopics. We also believe that the postgraduate college should start introducing laparoscopy surgery, probably at intermediate level as a must for senior trainees. In-house, we hope to design an ectopic pathway document that tracks patients from when they get admitted to when they get discharged, so that we don't have episode of missing documents or missing data. Thank you very much. And this is us actually doing a laparoscopy surgery on the day the Sogon started this session. Thank you very much.